Hello, everyone. Last webinar, we introduced International Patient Safety Goal 1, 2, and 3. This section, we continue to introduce IPSG 4, 5, and 6. Goal number 4, ensure safe surgery. Goal number 5, reduce the risk of healthcare associated infections. Goal number 6, reduce the risk of patient harm resulting from falls. IPSG number 4, the hospital develops and implements a process for the preoperative verification and surgical invasive procedures set marking. IPSG 4.1, the hospital develops and implements a process for the timeout that is performed immediately prior to the start of the surgical invasive procedure and the sign-out that is conducted after the procedure. Significant patient injury and adverse and sentinel events resulting from wrong site, wrong procedure, and wrong patient surgery are ongoing concerns for hospitals. Such events can result from ineffective and inadequate communication between members of the team conducting the surgical and invasive procedure, lack of a process for marking the procedure site, and lack of patient involvement in the site marking. In addition, inadequate patient assessment, inadequate medical record review, a culture that doesn't support open communication among team members, problems related to illegible handwriting, and the use of abbreviations are frequent contributing factors. Surgical and invasive procedures include all procedures involving an incision or puncture, including but not limited to open surgical procedures, percutaneous aspiration, selected injections, biopsies, percutaneous, cardiac, and vascular diagnostic or interventional procedures, laparoscopies, and endoscopies. Organizations need to identify all areas in a hospital where surgical and invasive procedures take place. For example, the cardiac catheterization lab, interventional radiology department, gastrointestinal lab, and the like. The approach the hospital takes to ensure safe surgery applied to all areas of the hospital in which surgical and invasive procedures occur. Universal protocol for preventing wrong site, wrong procedure, and wrong person surgery. The preoperative verification process, marking the surgical site and the timeout that is held immediately before the start of the procedure. Preoperative verification is an ongoing process of information gathering and confirmation. The purpose of the preoperative verification process is to verify the correct patient procedure and the site, ensure that all relevant documents, images, and studies are available, properly labeled and displayed. Verify that any required blood products, special medical equipment, and implants are present. They are very elements of the preoperative verification process that can be completed before the patient arrives at the preoperative area, such as ensuring that documents, images, test results and the paperwork are properly labeled and match the patient's identifiers. Waiting until the time out to complete the preoperative verification process may unnecessarily delay surgery if paperwork or image are not labeled or available when surgery is about to begin. It is more likely that portions of the preoperative verification may occur more than once or in more than one place. For example, the surgical consent may be obtained in the surgeon's office, and then verification that has been completed may take place in the preoperative holding area. Marking a surgical invasive site involves the patient and is done with the instantly recognizable and unambiguous mark. Ideally, an X is not used as a mark, as it may be interpreted as not here or wrong side and could potentially lead to errors in patient care. The mark must be consistent throughout the hospital. The site is marked in all cases involving laterality multiple structures like fingers, toes, lesions, or multiple levels like a spine. The surgical invasive procedure site marking is done by the person who will perform the procedure. This person will do the entire surgical invasive procedure and remain with the patient throughout the entire procedure. In cases of surgical procedures, the responsible surgeon typically performs the surgery and the level would mark the site. There are different titles used for the responsible surgeon, such as attending or consult surgeon. For non-surgical invasive procedures, it may be a physician who will do the procedure, and it may take place in an area of the hospital outside of the operating room. There are circumstances when a trainee may perform the site marking. This is when the trainee performs the entire procedure requiring minimal and no supervision from the responsible surgeon or physician. In these circumstances, the trainee marks the surgical site when a trainee is in the role of assisting the responsible surgeon or physician. Only the responsible surgeon or physician may perform the site marking. The site marking may take place any time before the surgical invasive procedure begins, as long as the patient is actively involved in the site marking whenever possible, and the mark is visible after the patient is prepped and draped. Examples of when patient participation may not be possible include patients who are not competent to make healthcare decisions, children and patients require emergent surgery. The timeout is held immediately before the start of the procedure with all team members present. During the timeout, the team agrees on the following components: correct patient identity, correct procedure to be done, correct surgical invasive procedure site. The timeout allows any unanswered questions or confusion to be resolved. The timeout is conducted in the location at which the procedure will be done and involves the active participation of the entire team. The patient does not have to participate in the timeout. When the timeout is complete, No one from the team leaves the room. Completion of the timeout is documented and includes the date and the time the timeout was completed. The hospital determines the amount and the type of any additional documentation. The WHO surgical safety checklists includes a sign-out process, which is conducted in the area where the procedure was performed before the patient leaves. The following components of the sign-out are verbally confirmed by a member of a team, typically a nurse. Name of the surgical invasive procedure later was recorded written. Completion of instrument, sponge, and needle counts as applicable. Labeling of specimens. When specimens are present during the sign-out procedure, labels are read aloud, including patient name. Any equipment problems to be addressed as applicable. This manual, the operating team is understood to comprise the surgeons, anesthetists, nurses, technicians, and other operating room personnel involved in surgery, much as an airplane pilot must rely on the ground crew, flight personnel, and the air traffic controller for a safe and successful flight. A surgeon is an essential but not solitary member of a team responsible for patient care. All members of the operating team play a role in ensuring the safety and the success of the operation. This manual provides guidance on using the checklist, suggestions for implementation, and recommendation for measuring surgical services and outcomes. Different practice settings should adapt it to their own circumstances. Each safety check has been included based on clinical evidence and expert opinion. That is, inclusion will reduce the likelihood of serious, avoidable surgical harm and let adherence to it is unlikely to introduce injury and unmanageable cost. The checklist was also designed for simplicity and brevity. Many of the individual steps are already accepted as routine practice in facilities around the world, though they are rarely followed in their entirety. Each surgical department must practice with the checklist and examine how to sensibly integrate these essential safety steps into their normal operating workflow. The ultimate goal of the WHO surgical safety checklists is to help ensure that teams consistently follow a few critical safety steps and thereby minimize the most common and avoidable risks, endangering the lives and well-being of surgical patients. The checklist guides a verbal team-based interactions as a means of confirming that appropriate standards of care are ensured for every patient. In order to implement the checklist during surgery, a single person must be made responsible for performing the safety checks on the list. The designated checklist coordinator will often be a circulating nurse, but it can be any clinician participating in the operation. The checklist divides the operation into 3 phases, each corresponding to a specific time period in the normal flow of the procedure. The period before induction of anesthesia, the period after induction, and the level surgical incision. The period during or immediately after wound closure, but before removing the patient from the operating room. In each phase, the checklist coordinator must be permitted to confirm that the team has completed its tasks before it proceeds onward. As operating teams become familiar with the steps of the checklist, they can integrate the checks into their familiar work patterns and verbalize their completion of each step without the explicit intervention of the checklist coordinator. Each team should seek to incorporate use of the checklist into its work with maximum efficiency and minimum disruption, while aiming to accomplish the steps effectively. Checklist in detail as following. Before induction of anesthesia, has the patient confirmed his or her identity, site, procedure, and consent? Is the site marked? Is the anesthesia machine and the medication check complete? Is the pulse oximeter on the patient and functioning? Does the patient have no allergy? Does the patient have a difficult airway aspiration risk? Does the patient have a risk of greater 500 milliliter blood loss in children 7 milliliter per kilogram? Before skin incision, confirm all team members have introduced themselves by name and role. Confirm the patient's name, procedure, and where the incision will be made. Has antibiotic prophylaxis been given in the last 60 minutes? Anticipated critical events. To surgeon, while the critical or non-routine steps, how long will the case take? What is the anticipated blood loss to anesthetist? Are there any patient-specific concerns? To nurse team, has sterilization, including indicator results have been confirmed. Are there equipment issues or any concerns? Is essential image displayed? Before patient leaves operating room, the name of the procedure, completion of instrument, sponge, and needle counts. Specimen labeling. Read specimen labels aloud, including patient name. Where there are any equipment problems to be addressed, surgeon, anesthetist, and nurse review the key concerns for recovery and management of this patient. We have a video, the National Health Care Service in Scotland, a video will present to practice a WHO surgical checklist procedure.
I'm Anna, one of the nurses looking after you when you're in theatre today. How are you?
I'm fine, love.
Okay. Could you just tell me your name and date of birth, please?
Janina Davidson.
Okay.
12/6/37.
Okay, and your hospital number is correct. What operation are you having done today?
Gallstones.
Gallstones. Okay, so that's the consent form.
Yeah.
I just need to check that you've signed it.
Yep.
And that's your signature.
That's my signature, yeah.
And you're happy with everything?
Yes.
Okay, that's fine. And the surgical sign is not marked because it's not applicable with this one. Are you happy with machines inside and here?
Yes, machines are checked inside and
the drugs?
all the drugs ready.
Okay, are you allergic to anything?
No.
Okay, and difficult airway aspiration risk?
Not anticipated, no.
Okay, any blood loss expected?
Minimal.
Okay, so we're just going to go ahead now.
Thank you.
Ready for timeout?
Okay.
Can everyone introduce themselves by name and role?
Mark Kenny, consultant anaesthetist.
Sampal Chanel, anaesthetic registrar.
Paul Ziprin, consultant surgeon.
George Peach, surgical SHO.
Angela Zupan, circulating nurse.
Natalie Modeste, scrub nurse.
Andre Chow, surgical registrar.
Anna, anaesthetic nurse.
Okay, what's the patient's name, procedure and site?
Janina Davison for laparoscopic cholecystectomy. Her name tag's already been checked.
Okay, any expected blood loss?
Minimal.
Specific requirements?
Laparoscopic cholecystectomy, which has been checked already.
Okay, the critical steps?
Possibility for conversion to open surgery.
Any specific concerns? Anesthetics?
None.
ASA?
2.
And monitoring equipment?
All present.
Okay, is it sterility checked?
Yep.
And any equipment issues?
I've got the standard laparoscopic equipment. Would you be requiring anything extra?
Well, we have the open set on standby.
Antibiotics?
1.2 grams of augmentins in the patient.
And warming?
Bear hugger.
Hair removal?
Not required.
Glycemic control?
Not indicated.
And DVT prophylaxis?
TED stockings as standard.
Imaging displayed?
Not required.
Okay, thanks.
You ready for sign out?
Okay. What's the name of the procedure?
Laparoscopic cholecystectomy.
Are the counts correct?
Counts correct.
Okay. In the specimen, it's labelled Janina Davidson gallbladder.
Yes, that's great.
And any equipment problems?
No.
No.
And key concerns for recovery?
No special concerns.
Thanks.
Now we will introduce Goal 5, reduce the risk of healthcare associated infections. IPSG.4-6, the hospital adopts and implements evidence-based and hygiene guidelines to reduce the risk of healthcare associated infections. IPSG.4-6, hospital leaders identify care processes that need improvement and adopt and implement evidence-based interventions to improve patient outcomes and reduce the risk of hospital-associated infections. Central to the elimination of these and other infections is proper hand hygiene. Evidence-based hand hygiene guidelines are available from the World Health Organization, WHO, the U.S. Centers for Disease Control and Prevention, CDC, and various other national and international organizations. The hospital adopts and implements current evidence-based hand hygiene guidelines. Hand hygiene guidelines are posted in appropriate areas, and staff are educated in proper hand washing and hand disinfection procedures. Soap, disinfectants, and towels All other means of drying are located in those areas where hand washing and hand disinfecting procedures are required. The patient zone is defined as the patient's intact skin and his or her immediate surroundings, colonized by the patient flora and the healthcare area as containing all other services, symbols for critical sites with infectious risk for the patient and critical sites with body fluid exposure risk. Two critical sites for hand hygiene in the patient zone, indications for hand hygiene depending on healthcare workers' movements between geographical area, the care environment, and the patient surroundings, often referred to as the patient zone and the healthcare zone. And on the tasks left performed in this area, healthcare activity is made up of the succession of tasks during which healthcare workers' hands touch different types of surfaces, patient objects, body fluid, and so on. Depending on the order in which this contact occur, pathogen transmission from one surface to another must be interrupted. As each contact is a potential source of contamination, it is during the interval between two contacts that the moments indications or indication for hand hygiene occur. The before indications are present when there is a risk of microbial transmission to the patient. The actions that correspond to these indications protect the patient. The after indications are present when there is a risk of a microbial transmission to the healthcare worker and or to the healthcare environment and to any other person present. The actions that correspond to these indications protect healthcare workers and the healthcare environment and ultimately are the patients. The right action at the right moment will contribute significantly to the maintenance of clean and safe care in the context of pathogens transmitted by hands. My 5 moments for hand hygiene approach defines the key moments when healthcare workers should perform hand hygiene. This evidence-based, field-tested, user-centered approach is designed to be easy to learn, logically and applicable in a wide range of settings. This approach recommends healthcare workers to clean their hands before touching a patient, before cleaning aseptic procedures, after body fluid exposure risk, after touching a patient, and after touching patient surroundings. IPSG 5.1, the risk of hospital-associated infections. Hospital leaders identify priority areas for improvement of hospital-acquired infections. Hospital leaders identify and implement evidence-based interventions, such as bundles, for all applicable patients. Evidence-based interventions, such as bundles, used to reduce the risk of healthcare-associated infections are evaluated by healthcare practitioners for compliance and improvement in clinical outcomes. Some patient care treatments and interventions have been identified as major sources of hospital-associated infections, such as surgical procedures, mechanical ventilation, and the insertion of central lines or interwearing catheters. Hospital-associated infections can severely impact a patient's emotional and financial well-being. They are a significant source of complications that can lead to further illness and even death. Many of these infections are preventable. Research studies suggest that implement practices designed to prevent hospital-acquired infections can lead to as much as a 70% reduction of those infections. The Institute for Healthcare Improvement, IHI, began developing and testing the concept of enhancing teamwork and communication in multidisciplinary teams in order to improve the clinical care provided to patients. This initiative led to the creation of bundles of care. Bundles are defined by the IHI as a small set of evidence-based interventions for a defined patient segment population, and a care setting that, when implemented together, will result in significantly better outcomes than when implemented individually. Examples of bundles include central line associated bloodstream infection, ventilator-associated pneumonia, catheter-associated urinary tract infection, surgical site infection, and severe sepsis bundle. Preventing central line associated bloodstream infections, 5 components of care. The first is hand hygiene. Second, maximal barrier precautions. Number 3, chlorhexidine skin antisepsis. Number 4, optimal catheter site selection with avoidance of using a femoral fan for central venous access in adult patients. Number 5, daily review of central line necessity with prompt remove of unnecessary lines. Preventing catheter-associated urinary tract infections for components of care. Avoid unnecessary urinary catheters. Insert urinary catheters using a septic technique. Number 3, maintain urinary catheters based on recommended guidelines. Number 4, review urinary catheter necessity daily and remove promptly. Preventing ventilator-associated pneumonia, 5 components of care. Elevation of the head of the bed between 30 and 45 degrees. There is sedative interruption and daily assessment of readiness to intubate. Peptic ulcer disease prophylaxis, deep venous thrombosis prophylaxis, daily oral care with chlorhexidine. Surgical site infection SSI prevention for components of care. Number 1, appropriate use of prophylactic antibiotics. Number 2, appropriate Hair removal. Use clipper rather than shaving with a razor. Number 3. Controlled post-operative serum glucose in cardiac surgery. Maintain post-operative blood glucose of 180 milligram or lower. Number 4, maintain normothermia temperature of 35.5 Celsius or more during the preoperative period. Severe sepsis bundle. Implement workflow for rapid assessment and intervention at the bedside and initiate septic bundle. 3 hours elements. Obtain blood culture prior to administration of antibiotics. Administer broad-spectrum antibiotics. Administer 30 milliliter per kilogram cholesteric for hypertension or lactate greater than 4 millimole per liter. We measure lactate initial lactate was elevated. Goal number 6, reduce the risk of patient harm resulting from falls. IPSG.4-6, the hospital develops and implements a process to reduce the risk of patient harm resulting from falls for the inpatient population. IPSG.4-6.1, the hospital develops and implements a process to reduce the risk of patient harm resulting from falls for the outpatient population. Many injuries in hospitals to both inpatients and outpatients are a result of falls. The risk for falls is related to the patient, the situation, and all the location. Risks associated with patients might include patient history of falls, medication use, alcohol consumption, joint or balance disturbances, visual impairments, altered mental status, and the like. Patients who have been initially assessed to be at low risk for falls may suddenly become a high risk. Reasons include, but are not limited to, surgery and or anesthesia, sudden changes in patient condition, and adjustment in medications. Many patients require reassessment during their hospitalization. All inpatients are assessed for fall risk using assessment tool and methods appropriate for the hospital patient populations. For example, pediatrics patients require a pediatric fall risk assessment tool. As a tool developed for adults will not accurately assess their risk for fall. In outpatient departments, patients are screened for fall risk. However, only those patients whose conditions, diagnosis, situation, and all location identifiers them as at risk for fall are screened. If fall risk is indicated from the screen, measures and interventions are implemented to reduce fall risk for those patients. Specific situations or locations pose a risk for falls. Patients scheduled for outpatient surgery involving a procedure, sedation, and anesthesia. A patient arrives at the outpatient department from a long-term care facility by ambulance. For a radiologic examination, the patient may be at risk of falls. In that situation, when transferring from ambulance car to exam table or when changing positions while lying on a narrow exam table. A physical therapy department, inpatient or outpatient, has many types of specialized equipment used by patients that may increase the risk of fall, such as parallel bars, freestanding staircases, and exercise equipment. Patients with joint and or balance disturbance, patients with visual impairments, pediatric patients under the age of 2. Okay, IPSG International Patient Safety 6 goals have completely introduced for you that can help your hospital to promote improvements in patient safety. Okay, thank you for listening.